The only reason that this has come to light recently is that the first week of May, there was a person who identified themselves as a pilot who was on X that posted, like, it's ridiculous that I need to land this helicopter a mile away from the hospital when my job is to bring this child to a hospital.
Hey there, fellow nerds. Welcome back to another episode of The Present Illness, the podcast where two physicians try to make sense of an increasingly sick and underdiagnosed world. I'm Arghavan, Salles, a surgeon scientist and your friendly neighborhood doom scroller in residence.
And I'm Alyssa, Burgart, an anesthesiologist and bioethicist who tracks news and health law like they're EKGs, full of spikes and surprises. The Present Illness is where we dig into public health, politics, culture, and ethics with a scalpel in one hand and a meme in the other. As a note to any new listeners, we often talk about topics that can be intense and be uncomfortable, so you might not want to listen to this with your little ones.
Big thanks, as always, to everyone who's tuning in from wherever, however, and extra love to our subscribers and those who follow us on any of our various platforms, and a special warm welcome to anyone who is just stumbling in from the Hantavirus outbreak.
Oh my gosh, how scary is that?
Yeah, it's definitely disturbing. I think the good news to the extent that there is any in an outbreak, is that it's a virus that typically doesn't spread human to human, although this specific strain that they've identified as the culprit here on this cruise ship is one that was known and previously documented to have had human to human transmission. Yeah, it's not great, not ideal. And the mortality rate, so the risk of dying from it, is pretty high, up to 40%. So that's kind of the not great news. But the R naught, which is like how many people each person is likely to infect, ranges between 1 and 2, which is not super high. Measles is somewhere over 15, above 15. So that means it's not going to have a penchant for spreading quickly. And because a lot of people die, that also decreases the spread. I know that's quite a morbid thing to say. And in the past, it was thought to require pretty close contact for human-to-human spread. But I was just reading this morning an article from the New England Journal on an outbreak that had happened in Argentina, that basically there was a guy who had gone to a birthday party, and multiple people at the birthday party had gotten it from this guy. And he was, presumably not having close relations with many people at this birthday party. So it's a little up in the air how close you have to be. But the other thing that was interesting in that paper was they thought the transmission window was actually really narrow, because the latent period, or I guess the delay from when you get infected to when you start to have symptoms, can be quite long with hantavirus. It can be up to 8 weeks. And then usually if there's a severe infection, it just happens and then people die relatively quickly. And so it's really that's what they theorize in this paper, was that like that first day that a person is febrile is like maybe the only time that they're actually able to transmit the virus, as opposed to, things where people are transmitting while they're asymptomatic. Those are the ones that tend to spread quite a lot. But it sounds like most of the time people are only infectious when they're quite sick. And so what we saw in this case was there was an original patient who was sick, who we now believe got sick in Argentina, and then developed symptoms and died on the ship. And then his wife was then carrying his body off the ship a couple of weeks later. So the body remained on the ship for a couple of weeks. And then she developed symptoms. So people who were on her flight that was taking her to Johannesburg were exposed. And then she died shortly after she got to Johannesburg. So it does seem like it ramps up pretty quickly. Anyway, we'll see what happens. There's been multiple other people who are suspected to have a hantavirus infection. There's another person who died on board the ship. We're recording as of May 7th. So as of today, there's been 3 people who've died, multiple other people with suspicious infections, one person who had left the ship and is in Switzerland and is infected, and then multiple people in France who had been on that flight with the wife of the first person who died, who have some symptoms, but they're currently, as of again, May 7th, being tested. It would be a very short incubation period for them if they already had hantavirus. So it's definitely possible they have something else. It's a little bit too soon to tell. But the bottom line is it's unlikely to cause, a global pandemic for all the reasons we stated. But certainly people who were on the ship are at great risk. And we know, I believe as of today, it's more than 30 people have left the ship and already flown back to their home countries, including some coming back to the United States. And those people could be in an incubation period and totally have no idea. So we'll just have to wait and see.
Well, that all sounds really unpleasant. To your comparison about measles, just for folks to kind of think about this whole concept of R naught, measles, you can be infectious for like 28 days. So there's a long period of time, both before you're sick and while you're sick, that you can be shedding virus and getting other people ill, which is part of why it spreads so rapidly. It's interesting. I had, until this story broke, I had no idea that there was any form of hantavirus that could be passed from human to human, because you typically get it from breathing in aerosolized virus from like rat droppings and gross rat stuff.
Like rat feces, rat urine, and rat saliva.
Yeah, and so I used to work at a ranch in New Mexico, and when you would start working there in the summer or the late spring, you would get sent out to these remote cabins where we would live. And the first thing that you had to do was basically the ranch gave us a bunch of PPE, and we would have to spray down the entire inside of the cabin with a dilute bleach solution in order to both, because mice and rats will move, and any sort of a rodent in the winter will be looking for a place to live, and so the whole place would just be covered in rodent poop. So you'd have to like cover everything in bleach to like also to weigh down some of the particles, and then we would have to clean everything out, and then you would bleach everything again, and with all the windows open while you were doing this, and wearing respirators and other gloves and protective stuff. So it was so I have been thinking about hantavirus for a long time because of that. But I'm very, have you ever been on a cruise?
No.
Nor have I. I don't think those are for me for like so many reasons. And every time I'm like, maybe I'm wrong, maybe I should go on a cruise, and then something like this happens, I was like, absolutely not. No shade for those of you who maybe like love a cruise. I know there's people who love cruises. I think it freaks. I don't know.
There's a lot that can go wrong. And the last thing I'll say on this before we get into our main topics is just that, as has been the case, this even more emphasizes how important it is to wear a mask when you're flying, because you really don't know what has gone on with the people right next to you, or even the people rows back, because especially in the part once you've boarded but you haven't taken off, and once you land before you deplane, the circulation, or the ventilation I should say, is quite poor on planes. So if you weren't masking already, just given that there are some folks somewhere in the United States who have been on the ship, it really isn't a terrible idea to start doing that now. And that would be with a high quality mask if you can, an N95 or a KN95 rather than a surgical mask. Anyway, all right, let's move into our first topic for today.
Well, just very briefly, because you're talking about travel, you know this, our audience doesn't know this. I am about to take a trip for the next 2 weeks. And so Arghavan mentioned, we are recording this on May 7th. Y'all are going to get this in about a week when this episode comes out. So just so you know, we're just trying to work ahead and keep you all entertained.
As best we can.
As best we can. And so that's why whatever, all the things that we're talking about, they're very prescient on May 7th, and we suspect they'll still be relevant in a week. But just so y'all know, if something wild has happened with hantavirus in the last week, I just want you to know that I won't know anything about it, because if I don't have Arghavan to tell me, I won't know.
Yeah, you're going to be enjoying your time off, as well you should. But yeah, why don't we start with whatever you're going to share with us today?
Okay, well, this comes at the request of my friend Louise. She reached out to me on Instagram, where she follows our shenanigans. And she said, hey, could you please talk about this Seattle children's helicopter situation? And I thought, what a perfect topic. So for those of you who have not already heard about this story, Seattle Children's Hospital is the premier children's hospital in Washington State. It's one of the main places where people from, remote parts of Washington, Oregon also has a children's hospital that also does a lot of things, but certain things even there will be sent to Seattle Children's. People who need remote care from places like Idaho and Montana and Wyoming, many of these folks are being sometimes airlifted all the way to Seattle Children's
And
Hospital.
Alaska, I think.
And Alaska, because kids need highly specialized care. There's only so many hospitals in the country who can do certain levels of NICU, for example. So neonatal intensive care units have grades for what they're able to provide. So sometimes children might be born at a hospital that has a certain kind of a NICU, but it doesn't have the higher level of care, for example, doing pediatric cardiac surgery. And so those kids may need to be airlifted by a helicopter to places like Seattle Children's. So this is the norm. If you are a person who works at a major either adult or children's hospital, the sound, the beautiful sound of a helicopter landing is quite common. My office at Stanford, where I work, I get to hear many of my meetings are interrupted by the sounds of helicopters. And while they're noisy, it always tells me like, wow, somebody really needed to get here quickly. So there's the situation that's happening in Seattle Children's. It's actually an old situation that has just suddenly come to light for most of us. Most of us were not aware of this situation. So there is a incredibly wealthy neighborhood that is close to Seattle Children's Hospital. It's called the Laurelhurst community. And the Laurelhurst community is apparently like the old money place in Seattle. Very wealthy, oftentimes topped as one of the wealthiest areas to live in Seattle. I watched like a real estate video about it, so I'll link to that in the show notes because I had never heard of it. And apparently, way back in 1992, there was a guy named John McFalls, who I guess is a Laurelhurst resident, and he made a complaint in 1992 about the noisy neighbors that Seattle Children's made, that there was just too many helicopters bringing in sick kids.
How dare they? How dare they try to save children's lives? I mean, I'd like to watch my TV show in peace. Gosh darn it.
Yeah. Well, there was a pediatric resident at the time who is now in her 60s, who, wrote back a fiery response about NIMBYism, which NIMBY means not in my backyard for folks who haven't heard of that. So the idea that like wealthy people want to have different rules for them, they deserve quiet and peace and all of that. So it turns out that there was this complaint that was made in 1992. Ultimately, there was an agreement that was made between the city of Seattle on behalf of this Laurelhurst neighborhood and Seattle Children's Hospital that children who are critical, who must be transported by helicopter to the hospital, will go to the hospital, but that those that were not critical enough, I guess, would be taken 1.2 miles away to a different helipad that is on the University of Washington campus. And then those patients are transported from the helicopter into an ambulance, and then the ambulance has to take them to Seattle Children's. Now, first of all, this is totally asinine because if you're sick enough to need to transfer a child by helicopter, you're pretty sick. Pretty sick. And there's all of these conversations for folks who may not be aware of this. If a hospital is asked to accept a child as a transfer, for example, there's a whole group of people who they take those calls, they get the information that's needed so they can decide if they're going to accept the transfer. And then if it's a transfer that needs to be done in for example, a helicopter, they help make the arrangements. Do we need to send a team to get that child? Is there a different life flight team that's going to bring that child? These helicopters they're sometimes called air ambulances, but in reality, they're sort of air ICUs.
Mm-hmm.
So they have ventilators in them. Many of the larger helicopters, so there's a pilot, and then there's usually a nurse and a paramedic who might transfer in that vehicle. But additionally, like in our hospital, we'll send an ICU doctor to go get the kid so that they can literally have moment by moment care provided by an intensive care doctor while the child's being transferred. So I have never, I'm not saying it's impossible, but like if you need to be brought to a hospital in a helicopter, like usually you're pretty sick.
Mm-hmm.
And needing to then do another transfer. And as an anesthesiologist, I transfer patients like from the ICU to the operating room, from the operating room back to the ICU,
Mm-hmm.
from the operating room back and forth to like pre-op and the recovery room. Transports are one of the most dangerous parts of what I do. And so when you're transporting a person in the sky and then in the, on the ground in an ambulance, each time you transfer a patient, you are at risk for complications.
Mm-hmm.
Breathing tubes coming out
Yep.
of place. You're jostling a child who's very ill or an adult. I mean, you could have these same arguments about adults. So, but the Laurelhurst area apparently just really doesn't like how noisy it is. Apparently, the helicopters landing at Seattle Children's, they find it very disruptive. It's close to a school and it kicks up a lot of wind, and they claim these are safety concerns.
But can I just ask a question? Could they not live somewhere else? Did they not know there was a
honestly,
hospital right there?
well, you know what's super fun? They also, this same neighborhood apparently also tried to prevent Seattle Children's from expanding their hospital in 2009 because they didn't want it to get any bigger. And the reality is that if there is any community in the Seattle area where people could afford to live someplace else, it sounds like it's Laurelhurst. I mean, their average income in that neighborhood apparently is over $250,000 a year.
I just can't imagine. Look, I get it. Sometimes my neighbors are doing construction or whatever. It's noisy, it's annoying. But I can't imagine sitting in my house thinking, I can't believe those children are causing so much noise. Like, I can't process that for me, like as an individual, to be upset that children are getting life-saving care. Because that's what I hear when I hear those, like when you're saying I hear someone really sick. Yeah, I hear someone getting life-saving care. And I feel concerned for them and their family. Like that's what I feel. So I just can't, I have a hard time wrapping my mind around the thought process to be like, it's just too noisy for me.
And like, again, like helicopters are noisy. Like my partner works for a company that's making an electric airplane. And I think one of the things that's really cool about that is it's a lot quieter. They take off and land like a helicopter. And from the time, many years ago when he started working there, I was like, oh, this would be awesome because they're so much quieter than these helicopters. But again, the solution is not don't let kids get to the hospital as fast.
I mean, just imagine like, again, these people, if their own child was sick, I can't imagine that they would want that child to have to go into a helicopter and then come down on the ground and get transferred into an ambulance just to get eventually to the hospital. Like obviously, not only are there the risks of transferring, as you discussed, but also that's adding time to the trip.
Oh, and you know what else it's adding? So it's adding time, which is absolutely, and time is critical. Minutes are critical. These things are air ICUs, but they're not full ICUs. They're transport ICUs. The parents also get charged for the ambulance ride on top of getting charged for the helicopter ride.
I mean, why don't these people in this neighborhood get charged for the ambulance ride?
Great question.
That seems like, you know what, that might be a deal, like you want this crazy thing to happen and extend the amount of time it takes a child to get to their, the hospital that they need to go to, and you want to charge their parents more? No, you're going to at least have to chip in. How about that? Let's see how they feel about it if that's what they had to do.
So I'm going to, so I've been looking into this, story so that I could tell you about it. And the Reddit community for people who are pilots is hilarious on this topic. So there's somebody who was like, "Oh, have you heard about, the Laurelhurst neighborhood not wanting to have helicopters?" I think it's time for us to start doing a lot more aerial photography over that part of Seattle. And there's like all of this back and forth amongst these small plane pilots around like, where how close they can be to the ground, because they need to, there's a lot of air FAA regulations around that. There is a really funny satirical piece from The Needling, which is kind of like The Onion, but it's for Seattle. It's a satire piece. And they had a funny thing about how Laurelhurst is not a gated community, so everyone should just start driving through there at 3 a.m. making noise. And like, I don't want anybody to be harassed. And actually, Seattle Children's initially had a statement that they had put out saying like, we're eager to reassess this agreement with Seattle, but they ended up having to update it because a bunch of people in Laurelhurst apparently were being harassed over this, and so they were like, well, listen, we don't want you to harass anybody. Please stop doing that. We're eager to revisit the agreement, but please don't harass people.
Yeah.
So
what's the current status there? Is it right now the case that they have to do this transfer thing, or is that something
yeah, this is
what it is right now?
That is how it is now, and that's apparently how it's been for decades. And the only reason that this has come to light recently is that the first week of May, there was a person who identified themselves as a pilot, who was on X, that posted like, "It's ridiculous that I need to land this helicopter a mile away from the hospital when my job is to bring this child to a hospital." And like by these athletic fields, like it's got to be totally bizarre. And so I've also seen some interviews in the Seattle news area, interviewing people who have had to do this with their very sick children, and how distressing it is to have like another thing to worry about, especially when you're talking about transferring a critically ill adult is very difficult. Transferring a critically ill child, just the margins for error are even narrower and even more challenging. And I don't say that in any way to diminish adult care, simply to point out that like, because of kids' metabolic rates, because of their lung volumes, because of their size, it's just that there's no room for error. And so any additional time, and these additional transports, I just think it sounds dangerous. And the other thing too, Seattle Children's has, like they put out a report every year on how many helicopter flights came in and out of the area for patients. So, that stuff's all available. I'll put a link to it in the show notes. But Seattle Children's happens to be built in a place that is incredibly affluent. And so we are seeing through this, the revelation of this longstanding agreement, to show how a community with a lot of money and power appears to have been able to really impact the quality of care that certain children can get who are brought to that neighborhood to get care. And there are people from the Laurelhurst neighborhood who have said, like, we support these kids getting to the hospital as quickly as possible. There's a faction of folks apparently in Laurelhurst who are pretty committed to this noise issue. So I'll put a link to a summary. Also, there's a really good summary in a magazine called The Stranger. And I'll put a link to the original Noisy Neighbor complaint from 1992.
Yeah, that would be interesting to see. I mean, I was just looking while you were talking. I was looking to see if I could quickly find that post on X. I did find the whatever
it's been deleted. Yeah.
Oh, I see. I found the Needling or whatever it was that you were talking about. Yeah. But I didn't find the original. But, it also makes me think about one thing that we're seeing that has a lot to do with housing inequality too, is the data centers. That we talked about briefly before, and I don't want to spend a lot of time on it, but people with money have so many different privileges in our society. But one is that, yes, they can wield their wealth to make it harder for children to get healthcare, and they can make sure that their community, going back to your NIMBY phrase, that they can make sure that their community is not where the pollution is happening from these data centers. They can make sure their community is not where there's noise from these data centers. They can make sure that they're protected, and then they can still make use of all whatever it is, the AI or whatever else that's being supported by these data centers. So they can have the benefit of those things while making sure that all the adverse effects are mostly affecting low-income communities and people of color.
We should do a whole episode on data centers. I just, the talk I gave recently on AI ethics and healthcare, data centers was a big part of what I talked about. I think there's a lot there, especially the environmental impacts to communities and the ways that that contributes to chronic health. Like a lot to unpack.
Is there anything else you wanted to share about the helicopter situation?
No, I think we're done talking about helicopters.
The topic I wanted to talk about today is something we've mentioned briefly before, which is shingles vaccine. So I finally made the time to get it all together. And the kind of upshot is that there's multiple studies now that suggest the shingles vaccine, in particular the live attenuated shingles vaccine, may be protective for dementia to some degree.
Okay. Can I pause you for just a second?
Yeah, of course.
Can you tell our listeners just like super briefly, what is shingles?
Shingles. Okay. So people of our age, many of us had chickenpox when we were younger, and shingles is a reactivation of so chickenpox is a herpes virus, and herpes zoster is the reactivation of chickenpox, and it's called shingles. How it looks clinically is it's a rash that is very itchy and often very painful that happens in a specific nerve region. So if it's in your face, it'll be like this, maybe this section, which is your trigeminal nerve, or mandibular, whatever. It's in a very specific nerve. It affects a specific nerve root typically. So it might be like in your chest, it might be one specific band across your rib cage.
Because the virus lives in your spinal cord, and when it gets reactivated, it activates along a neural pathway.
Yeah, and it usually does this in moments of stress or when our immune system is down for whatever reason. So it's just not. It's an incredibly unpleasant. I have not had a shingles episode, but from what I've seen and read, like it's very uncomfortable. It's very painful, and it can be very limiting in terms of your abilities, depending on which part of your body is affected. So
I remember when I was in residency and I was rotating in our pain clinic, we would have patients who had gotten trigeminal shingles, and it's so painful.
Yeah.
And if you don't treat it really well, people can actually have chronic severe pain from it.
Yes. And people can have, as with anything else, multiple episodes of shingles. So it's not like you just have it once, and let's say you have bad luck and you have it once and then you're never going to have it again. It can be reactivated many, many times. And so it is recommended that people get 2 doses of the shingles vaccine starting at age 50 in the United States. That's what's recommended to prevent shingles.
God, 50, you're threatening my way of life. I feel like that's not that far away.
I know. I don't like to think about it too much. But every year, just getting a little closer. Anyway, so it's very interesting. The data has been, the person who's behind most of these studies is at our institution, and actually in my department, Pascal Geltzetzer is his name. So I thought I might just summarize what these studies have shown. And they're very interesting from just a science perspective of like how they design these studies, but then also like very potentially practically meaningful for anyone, because we know obviously dementia is terrible, and if you can lessen your risk of doing that, decrease your risk of getting that, then of course you want to do what you can. So the first major paper that they published was in Nature. You might have heard of it. Kind of like a major journal. Anyway, so they published in Nature in April 2025. And these studies are all using a similar methodology. So I'm going to spend a little more time on the first one, just explaining it, but then it's kind of similar for the other one. So what they do is they take advantage of what he calls like a natural experiment. And that is that in different countries, the shingles vaccine became available on specific dates, and who was eligible for the shingles vaccine was based on specific ages. So this paper in Nature looked at Wales. And in Wales, the vaccine became available on September 1st, 2013, and it was eligible to anyone who was born September 2nd, 1933 or after. So people who were younger than 80. Anyone who was older, they were not eligible. So what that means is that if you look at people who were born just before that date versus just after that date, you get two groups that are pretty similar to each other, right? They're similar in age. They're all, in this case, in Wales, so they're in the same place. They have similar exposures. So there's no reason that you would think one group would say like have more cancer than the other, right? Because they're just born within a week of each other. And so they're kind of leveraging that, again, natural experiment that just based randomly on whether you're born before this date or after this date, you could be eligible or not for this vaccine. And then they looked at the outcomes with regard to dementia for patients in these two groups. And they did show, in terms of the methodology, they did show that there was no difference between the two groups on like their baseline health at the time of entry into the study, whether they had gotten a flu vaccine or other preventative health measures. Like, did they show different health behaviors? No, they didn't. They didn't have differences in dementia risk factors. They didn't have differences in statin usage, other things you might think of that could be associated with the outcome of interest here, which is dementia. And so what they found was that, and this is, I should say, about 280,000 people that they were looking at in Wales. And so those who were eligible for the vaccine had a significantly lower rate of developing dementia than those who were not eligible for the vaccine. And when they looked specifically at who actually got the vaccine, not just who was eligible, but who actually got the vaccine compared to who didn't get the vaccine, there was a 20% decrease in dementia over the 7 years that they looked at, which is a pretty big deal. And so I should say 20% relative reduction of risk of dementia. And the other thing that was interesting was that they found the effect to be bigger among women than among men. And so you might be thinking, okay, but why? Why would this vaccine have anything to do with dementia? And it's still an open question, but some of the theories are that the herpes vaccine herpes virus is associated with greater inflammation in the brain and is associated with more cerebrovascular disease, more amyloid, which is a protein that's been associated with Alzheimer's, more tau protein. And so it may be that the inflammation that may be caused by the herpes virus is decreased with the vaccine, the herpes zoster vaccine, which is the shingles vaccine. The incidence of shingles also is associated with greater risk of dementia. So more episodes of shingles is associated with more greater likelihood of dementia. So one way that there could be a decrease in dementia is just by decreasing the episodes of shingles. But the authors say that doesn't explain it enough. Like, the decrease that you would expect from just that alone is less than what you see with the data that they have.
I'm just seeing the Centers for Disease Control. Vaccination is over 90% effective at preventing shingles and post-herpetic neuralgia in adults 50 years and older with healthy immune systems. Adults, and it says adults 19 years and older who have weakened immune systems are at higher risk of complications and should get vaccinated.
That was actually one of the things they looked at in this specific paper that I'm talking about, the one in Nature, was the first thing they did in the paper was say, like, do we see less shingles in those who were vaccinated? And the answer is yes, you definitely do. So yeah, the vaccine is very effective for decreasing incidence of shingles. And so that may be one part of the mechanism by which the vaccine also seems to decrease the risk of dementia, but that doesn't seem to explain all of it. So another potential mechanism is just the immunomodulatory effects. So kind of non specific effects that can happen from vaccines, which seem to be greater among women than among men for reasons that we don't totally understand based on the differences between men and women's immune systems. Essentially, those are kind of two of the hypotheses that these authors suggested. And again, we don't really know. So that was the first paper, was in Nature, looking at 280,000 people in Wales. Then they did a similar analysis in Australia, and this is a paper that came out in JAMA, another paper, another journal people may have heard of. So JAMA, also in April of 2025, and here they had a much smaller sample for whatever reason. So they only had they started out with 100,000 patients, but only 20,000 of them were actually included in their final analysis. So much smaller sample. And they had a similar thing where on November 1st of 2016, the vaccine became available, the shingles vaccine became available. And it was available the way Australia did it for anyone who was ages 70 to 79. So they would have been born November 2nd, 1936. And again, they had a 7-year follow-up, and they found, again, a decrease in the incidence of dementia in those who were eligible versus those who were not. No difference between the two groups on 15 different diagnoses. They didn't have differences in baseline health. They didn't have differences in preventative health behaviors. They didn't have differences in risk factors for dementia. But what was interesting, so basically they found the same things that they found in the Nature paper, except that they did not find a gender difference. That was the only thing there. So there they found no heterogeneity by the gender or sex of the participants. Then they had another paper. This is the third and final one I want to talk about, which was in Cell. This is a great line of work for Pascal, Dr. Gelsetzer, because these are, for those who don't know, these are extremely high impact journals to be publishing in, and that's 3 so far in 8 months or whatever. And just for clarity, I've never published I have published in JAMA, but not research. I published an editorial. So anyway, this is amazing. Congratulations to Dr. Gelsetzer. So in Cell in December of 2025, they went back to the data from Wales. And this time they decided to not look at who's getting dementia, but to look at progression of dementia. So they looked at who went from not having dementia at baseline to developing mild cognitive impairment, and who went on to die from dementia as the cause of death. So the early signs of dementia and then the last stages of dementia, and whether there was any difference in the rate of those two things based on whether someone was on either side of that line. Again, remembering in Wales, it was in September of 2013 that you either were 80 on or after that date and you were eligible, or if you were 80 before that date, you were not eligible. So in that case, what they found was that of those 280,000 people who they looked at who did not have dementia, 7.3% of them got or developed mild cognitive impairment in the following 9 years. And there was a 1.5 percentage point decrease in the incidence of that among those who were eligible for the vaccine, 3.1 percentage point decrease for those who actually got the vaccine. So lower likelihood of developing mild cognitive impairment if you had no dementia at the start of the study. And there were about 14,000 people who had dementia at the start of the study. And among those people, there was a decrease in the incidence of death from dementia. It was about 8.5 percentage point decrease.
So just so I can make sure I understand that. So I'm hearing two things. One is less people developed dementia when they got vaccinated. But additionally, of the people who got vaccinated, they also died less often from dementia. They died of other things.
Correct. And what they also found in this analysis was that there was a decrease in all-cause mortality among those who had dementia. So even, yes, they were less likely to die from dementia, but if they had dementia, they were also less likely to die overall if they were vaccinated compared to not being vaccinated. So basically, what they found was that the life expectancy of people with dementia was longer if they were vaccinated with the shingles vaccine. And again, I'll just remind everyone, it was the live attenuated vaccine, which is not the one that's commonly given in the United States. And there are some data that suggest these non-specific immune effects of vaccines are more likely to happen with a live attenuated vaccine than with other forms.
So wow, now is a real terrible time though to have that conversation in these United States, to be frank.
Yeah, but the people who listen to us are up for it, so I think it's worth mentioning. But I think
demand better vaccines.
Yes, demand better vaccines. Good luck to us. But yeah, so those are the three main studies I wanted to highlight. They did more recently have another paper, similar setup, looking at data from Canada. And so there are limitations, of course, to these data. This is not a randomized controlled trial where they took people who were otherwise very similar and then gave the vaccine to half of them, not to the other half, and saw what happened. In fact, I think it would be very difficult to do that kind of trial. But I know they're trying to see if they can get funding to do that. But this is better in terms of the quality of the data. It's better than purely association driven analyses, which had been done before, just looking at people who had been vaccinated and people who hadn't been vaccinated. Again, because they're taking advantage of these specific dates when the vaccine became available and looking at people just on either side of eligibility, which really takes out a lot of the confounding that you would otherwise have in pure associational studies. So it's not, the gold standard randomized controlled trial, but it's also much better in terms of quality of data than just a correlational study. And so,
I did just want to say for people who are curious, who are in the United States, we know you have people who listen to us who are outside of the United States, but folks in the US, the shingles vaccine that we use here is called a recombinant vaccine. It's called Shingrix.
Yeah. And, I think what I don't know, and actually I should have looked at before this episode, is I think that you can request the live attenuated in the US. Is that, we'll have to fact check that. I don't remember.
Since I am not yet 50, I don't know.
I have some vague memory of a coworker telling me that they were able to do that, but I will fact check myself and I will put a note in the show notes to confirm or deny whether that's true. And it doesn't mean that there isn't an effect necessarily with the recombinant one, the Shingrix.
Don't know.
It's just that other data suggests it might be a smaller magnitude. And these specific studies have been done with the live attenuated because that is what was used in these countries that they're looking at with these specific dates.
I'm also, by the way, I'm looking at the CDC website, which take it with a grain of salt, but this looks legit. About 1 in every 3 people in the United States will develop shingles in their lifetime, and the risk increases with age. Which also, to your point, the fact that this, the Welsh group didn't start get vaccinating until they're 80 when they started this process. And, now the recommendations here in the US are to get vaccinated at 50. It also shows that, when you see that something is working well and helping with, in this case, preventing shingles infections, like the date that you can get it starts going down.
As it should, because the risks are outweighed by the benefits, right? And so we've seen that. The one last thing I want to mention, just by way of
when you use those ethics words, by the way.
I do think about those things, even though I'm not a bioethicist.
You're a good person.
Oh, thanks. So the thing I wanted to add too is that in that last study, the Salles study that was looking at progression of dementia, they did again find that gender difference. So the actually they found pretty much the majority of that difference was driven by women who had decreased risk of going on to develop mild cognitive impairment and decreased risk of dying from dementia. So it was almost in that specific study in the Cell paper, almost no effect for the men and like a pretty decent effect for the women, just throwing that out there. So in summary, it seems like from these data, there's a suggestion that the shingles vaccine decreases the risk of, at least from these data, decreases the risk of developing dementia, decreases the risk of development or evolution, I should say, maybe of dementia and death from dementia. And it has particular benefit, it seems, for women. Now, the authors theorize that they didn't find that in the data from Australia because it was such a small sample size relative. So, it's hard to know. We would need to see that replicated in other data sets because so far that gender finding was only in the data from Wales. And so I suppose there could be something very different happening there for some reason for men versus women. But as a woman, I found that very interesting. So I think it's useful. The reason I want to talk about it is science is very cool. And we don't have to understand how everything works to see that maybe it is working in some way. And as you said, shingles is very common. So regardless of all this, shingles is very common and it's very painful. So, we should all be following the recommendations and getting vaccinated when appropriate. But this has had me thinking, because I first heard about these data, last year, really has had me thinking whether I should just try to go get it earlier, and see if I can go find, obviously haven't done the research, to see if I can go find a live attenuated vaccine somewhere here. I don't know.
Yeah, and I think you would need, just in terms of the, whether your insurance would cover it if you're
but maybe
50.
It's worth it. Like, if you have the means, maybe it's worth it to pay for it out of pocket if it's going to, lower your risk of dementia. That seems, I don't know. Not that obviously everybody can afford to do that, but yeah, I don't know.
Yeah, it also makes me wonder, like, what is the early, and I don't know the answer to this, what's the earliest that any country is giving a shingles vaccine? Because you also, you need to think about, in terms of risks and benefits at a population level, like if people are highly unlikely to develop shingles before they're 50, unless they have, an autoimmune condition or something like that puts them at risk, then is there any point in giving it earlier? Do you need to give it again if you give it to somebody earlier? I don't know. Yeah. I hope that you and I both live to be very old.
Yeah, sometimes I wonder. When I was younger, I used to think that I should die by the time I was 60. That was like a random number that I had in my head, because I didn't want to get, it's a very ableist perspective. Like, I didn't want to become weaker and walk slower, and not that happens at 60 anyway, but that was the idea I had in my head, that I wanted to it's a terrible idea, but that's what
that's the argument that Zeke, I can hear that you have given up this argument. So
yeah.
that was Zeke Emanuel, who is a very famous bioethicist, has shouted from the hilltops that he thinks people shouldn't live past 70, and because he thinks, well, it's a very ableist perspective, as you have mentioned.
Yeah.
But if things like vaccination and good public health measures can help us have, good years where we are able to enjoy our life and interact with the people we love, and, we're going to need hip replacements. Like, it's, just need some maintenance.
It's true. We do need just some, long-term maintenance issues coming up. There's a little pit stop here, get wheels changed, as it were. But yeah, anyway, so I these are good questions, and I don't know, what's the earliest anyone's giving, any countries recommending a shingles vaccine, and how many doses would you need if you were to take it earlier? I don't know the answer, sure, but these are good questions. I'd just love to have a positive science story,
Yes.
Any positive story at all, really, but especially when it's center science, I think it's nice.
On that note, I think it's time for take 2 and call me in the morning.
Oh, right.
I go first. Yeah. What do you prescribe?
Yeah. So, my algorithm, has fed me some interesting things. This week, the one I want to highlight is a person named, their username is New York Turk. So I'm assuming they're Turkish. And they went to a Persian restaurant. And I don't know if folks are aware of this. There's a genre of content that involves going to struggling restaurants to see if their food is actually any good. And then if it's good, then you give like this really nice review. And then, hopefully more people go to that restaurant. So if folks know about Keith Lee, he's probably the most famous person to do this kind of content. And so I don't know too much about this particular influencer I'm talking about, but the video I saw was he went to this Persian restaurant because the daughter, I believe, of the owner had reached out to him and said, hey, like, my parents own this restaurant and they're working so hard. The food is so good, but like, it's just empty. And I don't know, how long they're going to be able to keep it open. So he goes to this restaurant and it is like empty. And it's in New Jersey. It's called Zaffron Bloom. I'll put that all in the show notes. But so he goes to this restaurant and orders like many things, much more than you normally would order. And he goes, I came from Virginia. I'm really hungry. Of course, he's wearing like a disguise and everything. And so he eats the food and he loves it. Like, just, it's still, Persian food is delicious. So fork found in kitchen. But anyway, he loves it. And he is raving to the owner about how much he loves it. And he decides to leave a really large tip because he knows that they're struggling. So I can't remember how much his food came out to, but he leaves a $200 tip. And the owner is like, no, you can't do that. You can't do that. Remember, we've talked about taro. He's like, no, you cannot do that. And he's like, it's just a tip. It's just, I really appreciate the food. He goes, no, it's way too much. You cannot, $20 is fine. You can't leave $200. And the guy's like, no, I'm just going to leave right now if you are going to be like this, because I'm leaving $200. And the guy is like, okay, let me go get a bag for your food, his leftovers. And so he goes and gets the bag, and he comes back and he goes, how can I possibly do business with you in the future if it's going to be like this? Anyway, that's just very classic Taro of like, the guy is struggling, the restaurant is empty, and somebody appreciates the food and wants to leave him an extra large tip, and he's fighting it. Like, no, you cannot leave me that much money. Anyway, so I appreciated seeing that highlighted in that very specific way. And this person did a follow-up video where he went back, and the restaurant was full. Like, there were so many people there. And that's one of the best things about this particular genre of content, is that often is the case. If the person, like, I could do a video like this, it would go nowhere. But for people who actually do that, that's what their account is for. Like, I saw this all the time with Keith Lee, where he would go to a place that was empty, and he would be there because someone had told him, like, hey, this place is really good, just not getting the attention that it deserves. And then he would like do his ratings, and the food would be delicious, and then line out the door. So it really is an impactful way to help these struggling businesses. And I just so appreciated that in a time when our president is calling Iranians sick and lunatics who are going to try to kill everybody. And there's just so much really nasty rhetoric about us. And he, also said, if folks remember, that we should all be blasted back to the Stone Age where we belong. It's nice to see a positive story involving Iranians. So thank you to New York Turk, and I'll put a link to both of his videos in the show notes. How about you? What's your recommendation for folks?
I saw a video online of a creator who was highlighting this very DIY map that this guy named Rick Ashman has made. It is a hobby project, and this map is this ultra detailed map of dialects across North America, in English dialects, and based on pronunciation. And so you can look at this map in immense detail and see how different, not just regions of the United States have different dialects, or regions of Canada have different dialects, but, zeroing in on Boston or New York, places where there are more regional differences, or like down in certain parts of the South. And you can see how, based on the pronunciation of a particular word, how it is that these little areas can be, you can recognize where somebody's from based on these. And so what I did from this video is I went and found the website so I could look at the map in more detail. And it is absolutely fascinating. The last time this was updated is 2018. So I hope that Rick Ashman will keep this up. I don't know, maybe he'll update it again in the future. But he has a whole section on a guide to the sounds of North American English, a bunch of articles you can read. He has some special interest and historical articles on how you pronounce caught versus caught, like the spelling of it. And it's just fascinating. I think dialects are fascinating. I love the sound of different dialects. I'm fortunate enough to speak some Spanish. I love hearing different Spanish dialects and kind of guessing where people are from. So I find that super interesting. And it reminds me also of, did you ever see the soda pop Coke map?
Oh, yes. Well, I don't know if I saw the map, but I saw the quiz, right? The New York Times had a quiz a long time ago, like, what do you call soda? And then it would like tell you something about like which part of the country you're from.
Yeah. And so there's a researcher who had like created the original soda pop versus Coke, who calls people from Georgia, Coca-Cola used to be made there. So a lot of people in the South call all soda Coke, which is very confusing. I'm from California and we call it soda. In the Midwest, people call it pop. So anyway, I just think it's fun seeing how across our country people use different words and they have different sounds that really tell you a story about someone's community and about where they're from. And so I just think it's cool. So I'll put a link to those.
Do you know Zay on TikTok?
No.
Zay, I'll put a link to one of his videos. Zay is a linguist, and this is what he talks about all the time, like all the time. And he, people send him videos or tag him in videos all the time when someone's like, can you guess where I'm from based on how I'm talking? And he does like pretty intense like analysis of how they're, exactly like you said, how they're saying specific words, and he'll narrow down and be like, okay, so based on this, I think you're from the South. And then based on this, I think you're either from Tennessee or whatever, like, and he gets very specific. And then he'll be like, so here's like the region, and he'll have a map. Like, this is the region I think you're from. And then he's almost always right. Like, I mean, I suppose he could be wrong and he just doesn't post those, right? Like, I don't know, but sure. It's very interesting to see these little differences in language that honestly, sometimes he points it out and I still can't hear it. Like, I don't know, it still sounds the same to me. But he picks up on so much and explains it all, like why this is different from that and which region says it this way versus that way.
Oh, cool.
Anyway, so if you're into that, you'll probably like Zay and his content.
That ranch that I mentioned at the beginning of the episode that I worked at, it drew in people from all over the United States. And I am such a mimic, like I'm good at accents. I like to, if I'm talking with somebody who has a particular accent, it takes me a lot of effort, a lot of resistance to not mimic it. Mm-hmm. And so I would come home from this summer job with like the weirdest accent. And I would have picked up different words and start pronouncing things a little bit differently. And people would be like, where are you? Like people who hadn't met me would be like, where are you from? Because you kind of sound like you're from here, but you also kind of sound like you're from Chicago. And you also kind of sound like you might be from Louisiana. And you kind of, so that was always really funny. And I think about that when I see these maps.
Mm-hmm, mm-hmm. Well, that's very cool. Yeah. Thank you for sharing.
Thank you.
I think that's it for this week's episode. If you didn't like what you heard, we did it once again. We did it. If you didn't like what you heard, this has been Fireside Chat with Dennis Prager. If you liked it, don't forget to subscribe to The Present Illness, leave us a review. Please tell other folks to check us out.
Is Dennis Prager you?
Yeah.
Ugh. Cool. Well, we know that you like high quality education that is not forcing conservatism down your throat. So follow us on TikTok, Instagram, and YouTube at The Present Illness, and stay on top of all of our TPI related news.
We are going to take 1 week off, so we won't be back with an episode next week, but in 2 weeks, we'll be back with another episode with more headlines, hot takes, and doom scrolling, hopefully wrapped in some laughs.
Until then, agitate, hydrate, take a nap. We'll see you next time on The Present Illness. Production by Arghavan, Salles, and Alyssa Burgart. Editing by Alyssa Burgart. Social media by Arghavan, Salles. Original music by Joseph Uphoff. Don't take medical advice from random people on a podcast. This show is for informational purposes. It's meant to be fun, and it's certainly not medical advice. So please take your medical questions to a qualified professional. This podcast is our hobby. It does not represent the opinions of our employers or anyone but ourselves.